Our next talk is about pain management. So we want to start with exactly what is pain. So the American Pain Society says that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. But the reality is, pain is whatever the experiencing person says it is, existing whenever he says it does. So there are types of pain: acute pain, chronic pain, breakthrough pain, which is the most important one for us to talk about and the most difficult to treat. This is a flare of pain that occurs when moderate to severe pain breaks through a regular pain medicine schedule. It can be of rapid onset, moderate to severe intensity, of short duration. Occurrence can be frequent. It may be incident to a certain activity or movement. It can be idiopathic, or it can be an end of dose failure. So total pain, we always need to remember, is physical, but there's also often components of emotional, psychological, or spiritual pain that all combine together to cause suffering. What are barriers to effective pain management? We need to be aware there are often patient and family barriers, barriers of ourselves, healthcare professionals, as well as barriers of the healthcare system and economics. Pain assessment is the first place to start. The initial evaluation should elicit changes in ADLs, including work and recreational activities, sleep patterns, mobility, appetite, sexual functioning, and mood that are affected by the presence of pain. We need to do a detailed history, look at past medical history, allergies, medications, review of symptoms and systems. And a psychosocial history is very important. We need to emphasize the effect of pain on patients and their families, as well as what patients' preferences among pain management methods. So we need to talk to them. Do they like pills? Do they like liquids? What is their preference? Because if we give them something that isn't their preference, they're not going to take it. What is the patient's goal for relief? We need to be sure, because some patients on the pain scale will give you their perception of pain, and they'll be perfectly acceptable with a pain level of 6. Other patients want a 0 or want a 2. So we need to know what works for that patient and what has helped them in the past. Associated symptoms. The presence of pain can affect sleep, physical activity, emotions, appetite, and social relationships. We need to think about cultural considerations. Different ethnic groups express pain and suffering differently. Culture can affect behavioral responses to pain and treatment preferences. They have to be assessed using similar pain assessment tools, and findings may or may not have similar meanings across cultures. 3 terms that seem to be used similarly across many different cultures. An ache is a low level of pain. A hurt is more moderate, and pain is usually intense. So consider pain the 5th vital sign. Ask about it at regular intervals and assess pain systematically. Believe the patient's self-report. They are your primary source. Use an easy rating scale. Multiple pain scales are available depending on your patient population. Not going to talk about those in the scope of this talk. Document efficacy of relief at regular intervals and choose appropriate pain control therapies. We need to empower our patients to control their course to the greatest extent possible. General principles of pharmacologic management. So the World Health Organization approach to drug therapy: by mouth, by clock, by ladder, for the individual, with attention to detail. So oral administration is always the most natural. Usually we should have people on a schedule, and we need to progress in a logical manner by a ladder instead of haphazardly. So the World Health Organization analgesic ladder. So rung 1 is mild to moderate pain. Generally can be controlled with non-opioids. You can use adjuvant therapies with this. Rung 2 is moderate to severe pain. Usually will require some opioid management, as well as non-opioids and adjuvants. And severe pain, the 3rd rung, will require opioids and often the other agents as well. So pharmacologic management. Effective pharmacologic management of pain, like many other conditions, requires the application of 2 basic principles. We need to individualize it, and we need to optimize administration. So determine the analgesic group desired, choose the appropriate route. Generally, the least invasive route is the most appropriate, and PO is usually optimal. Start with the lowest dose, titrate to effect. We always need to optimize that balance between analgesia and side effects. The most appropriate dose is the dose that works and has the fewest side effects for the patient. So key principles: give the next dose before the last dose wears off. So this is recommended for acute and for chronic pain. That you often have the problem with PRN medications, that people wait till the pain is very advanced and very severe before they give the next dose. So whenever possible, use around-the-clock maintenance. It will maintain an optimal level of pain relief, and it should be scheduled, which prevents recurrences of pain. Use PRN availability for breakthrough events, and before a painful event, anticipate that you may need analgesia or sedation if a certain test, a certain procedure, wound care, personal care, something that we know is painful or uncomfortable for this patient, we should anticipate it rather than wait for them to have it. So the non-opioids are basically your non-steroidals and acetaminophen. So these are used for mild to moderate pain. Non-steroidals are very good for bone metastases as well as for non-cancer bone and muscle pain. Acetaminophen is more for the minor aches and for fevers. Remember, it's not an anti-inflammatory. And with acetaminophen, we need to watch the dosage because we don't want to interfere with hepatic function. Adjuvant drugs are used to enhance analgesic effect. They can treat concurrent symptoms. They can provide independent analgesia, but they also are used in coordination with analgesia in all steps of the WHO analgesic ladder. So examples of these are steroids, antidepressants, anticonvulsants, phenothiazines, and anxiolytics. Opioids, which is going to be the crux of this talk, they act by altering the perception of pain by binding to specialized receptor sites and preventing the release of neurotransmitters. They're indicated for mild to moderate pain as well as moderate to severe pain. Short-acting opioids are used for breakthrough pain only, generally on a PRN basis. Although, when a patient does not have high opioid requirements, we can use, and we often do use, short-acting opioids on a scheduled basis because their total requirement doesn't meet the level of what's available in the long-acting agents. Long-acting opioids are used for continuous pain, and they should always be used on a scheduled basis, not PRN. So what are the side effects? Now, the common side effects of opioids are sedation, which is very common with the onset of therapy, often subsides within a few days. But we also have to remember that starting an opioid is often related to a period of sleep deprivation prior to the initiation because the pain was preventing patients from sleeping or sleeping effectively. Constipation is another common side effect of opioids. Tolerance does not develop. Prevention is the best management. And the rule of thumb is to always, when you start an opioid, you start a bowel regimen. You start a laxative at the same time. Every patient should be on both. Nausea and vomiting is very common when opioids are started. It's usually transient, may require PRN management at the beginning of the course of treatment. It is very uncommon for opioids to cause respiratory depression. It's an infrequent side effect if the patient is experiencing pain, and tolerance generally develops to this. Okay, dosage recommendations. So patients will often say, what's the maximum dose I can take of this? Well, there is no maximum dose. There is no ceiling on opioid dosing. The maximal dose is the dose beyond which there is no further analgesic effect. So the maximum dose is different for every patient. When titrating dosing, remember that when you titrate the long-acting or around-the-clock dosing, you have to titrate the rescue or breakthrough pain dosing as well. Short-acting opioids should always be available for those on long-acting opioid regimens. The total dose of rescue medications should be 10 to 15% of the 24-hour total of all opioids given every 2 hours as needed. Titrate dosing of the long-acting agent if repeated occurrences of breakthrough pain are reported. Now, you'll see when we show you an equianalgesic table that you calculate with the breakthrough pain dosing that's required if they meet the next level of long-acting agent to titrate that. So an equianalgesic dose chart, like I just alluded to, provides a guideline of doses and intervals between doses that can be titrated according to an individual's response. They're very helpful from switching from one agent to another or one route of administration to another, as in the patient who can no longer swallow, or the patient who is on IV medications in the hospital. Now you need to switch them to something that is amenable for home use. I have an equianalgesic chart that I carry around with me all the time. And if you're starting to take care of some of these patients and using opioids, it's a good thing to have on your phone or however you carry these things around with you. This is an example of an opioid conversion chart. And the important thing to note is that with these medications, there is conversion required. We do have to mathematically compute what they will need. If you look very quickly, you will see that 10 milligrams of IV morphine is equivalent to 30 milligrams of PO morphine, which is equivalent to 20 milligrams of PO oxycodone, and about 1.5 milligrams of IV dilaudid, as well as 12 micrograms of fentanyl transdermal. So you can see these numbers are all different. So it's not one-to-one, and very often people make mistakes because they don't realize the different potencies. I always like to bring this up because this is always a question that many healthcare professionals have, as well as patients and families. Everyone's always concerned about addiction. What exactly is addiction? An addiction is a pattern of compulsive drug use characterized by a continued craving for an opioid and the need to use the opioid for effects other than pain relief. So it's a psychological phenomenon: drug craving, aberrant behavior, drug selling, hoarding. Tolerance and dependence are physical phenomena, so they're very different than addiction. Opioid tolerance and physical dependence are expected with long-term opioid treatment, and they should not be confused with addiction. Tolerance refers to decreased effectiveness of analgesia over time, necessitating higher doses. Often with long-term therapy, the need for escalation slows and then trends down. Dependence refers to the presence of a withdrawal syndrome with abrupt cessation of medication. Tapering is necessary, as with many other classes of medications we use. So we see tolerance and dependence across the board. It's not just a pain management phenomenon. Pseudo-addiction. This is often equated with the drug-seeking behavior we see documented in people's charts. But in reality, it's often a sign of inadequate pain management. Patients are seeking more medication because they are still in pain. And it results in patient anger and isolation, as well as frustration with the healthcare system and avoidance of further care. So patients are often getting inadequate treatment in a crisis situation. Just going to mention non-pharmacologic pain management. There's physical modalities, which include, among others, radiation therapy, very good for bone pain in metastatic cancer patients, regional nerve blocks, cutaneous stimulations, vibration, massage, exercise. These are all effective in certain patients. Psychosocial interventions include psychotherapy, support groups, spiritual counseling, as well as family involvement in care. And cognitive behavioral therapies are a newer modality, which has been very effective for certain groups of patients using more holistic measures, including meditation, imagery, biofeedback. And music, art, and pet therapy are very effective for many patients, both for pain itself as well as for distraction. Patient and family teaching is critical to the success of pain management. We need to discuss the benefits and the burdens, expected side effects, expected time frame of those side effects in order for our analgesic regimens to be effective. Discuss the harmful effects of unrelieved pain. So while you're talking about the side effects of the medications, you need to also talk about what are the side effects of not using the medications, specifically affecting sleep and nutrition. So we need to identify specific goals of our pain management, pain rating desired, related increase in functional status, back to what's important to that particular patient. So what is morphine? I always want to talk about morphine because it just elicits such a response in both lay and healthcare populations. So morphine is the classic opioid. Other painkillers are compared to it in terms of potency, in terms of effectiveness. The majority of its analgesic effects are due to the binding of mu opioid receptors in the central and peripheral nervous systems. It's a drug with proven uses for pain relief, as well as relief of dyspnea and autonomic and hemodynamic effects that are proven beneficial in acute cardiac events. It's available in multiple doses and multiple formulations, making it flexible and practical to deal with in many clinical situations. Very often when patients have very advanced diseases, whether they're in hospice care or not, patients often get difficulty swallowing, whether it's a part of the disease process or just the lethargy related to the disease process. Morphine comes in a concentrated liquid called Roxanol, which is often used at end of life. It's formulated in 20 milligram per milliliter solutions, so that you can often start with a quarter or a half of a milliliter. And this medication gets absorbed right through the buccal mucosa in the mouth, so patients don't have to swallow it. It actually works faster than many PO medications because it's absorbed through the mucous membranes. So what's the elephant in the room? Just the word morphine. And healthcare providers must be comfortable with the word morphine and with the use of morphine and other opioids in order to best treat their patients and families. So we need to address their questions and concerns head on. Information is power, and repeated studies have shown that patients want explanations of their medications and treatments. And very often, what we as healthcare providers perceive as pushback, oh, the patient doesn't want that, is really just a desire for more information and explanation. So how strong actually is morphine? If you remember when I was talking briefly about the equianalgesic table, morphine is actually less potent than the oxycodone family, the fentanyl family, the dilaudid family. And people are often surprised to find out how much less potent morphine is than oxycodone or dilaudid. For example, 1.5 milligrams IV dilaudid. Patients are often taking IV dilaudid when they're in the hospital setting. That 1.5 of IV dilaudid is equivalent to 30 milligrams of oral morphine. So patients feel like they're being sent home from the hospital and hospice, and now I'm not getting 1.5 milligrams, I'm getting 30 milligrams. So what does that mean? So for some families that really have questions, really have concerns about it, I often show them the chart of equivalence to help them to understand better. Dyspnea, I'm just going to mention very quickly. Dyspnea because of its interreaction with opioid use. So dyspnea is multi-component with the physical symptoms of air hunger and increased work of breathing, which does cause a type of pain, as well as the secondary emotional response. So morphine, because it has its CNS effects, will treat both the physical discomfort of dyspnea as well as the feeling of dyspnea. So the patient is more comfortable. Often anxiety is a major component of dyspnea as well, and anxiolytic agents may need to be added. In cardiac disease, the acute coronary syndrome, we often see this in the advanced cardiac patient who is at home. Morphine relieves pain as well as decreases the autonomic nervous system activation and will have a hemodynamic effect, including a decrease in heart rate, blood pressure, and venous return. So very often hospice patients that have advanced cardiac disease have had repeated visits to the emergency room in the hospital. They don't want to continue that cycle of back and forth and back and forth. And they may or may not be aware that standard of care when they came in with their chest pain or acute dyspnea was that morphine was administered in the ER. So once they understand that this was what they were given before, and it can and should be used in the outpatient setting, they're much more comfortable with it. So quickly, some of the myths of morphine. First myth we hear all the time. People who take morphine die soon after because the morphine causes them to stop breathing. Well, yes, we can acknowledge that some patients do die soon after morphine is initiated, but that's generally because the medication was started too late in the disease course and their death was inevitable at that point. Morphine administration is not euthanasia. People will ask about that. It is meant for patient comfort. It is not meant to hasten the dying process, and it is not being used for that purpose. With morphine administration, the patient will die more comfortably from the underlying disease process that is killing them already, and not from the medication itself. A myth is that morphine is only offered to patients when death is imminent, and that is not true. Many patients take morphine for months and months, if not years, to keep them comfortable while they are still getting treatment or even when treatment is stopped. People who take morphine will get addicted. We talked about that already. We need to know and be able to tell patients the difference between tolerance and addiction. Addiction is generally when opioids are taken without underlying symptoms. Tolerance is expected, and titrating doses with disease progression is expected as well. People who take morphine will be so sedated they will not be able to function. The reality is many patients do have significant drowsiness when they start taking any opioid. The bodies build up a resistance to the sedating effect within a few days. Also, those first few days of opioids, patients often fall into a deep sleep because sleep has been evading them, or effective sleep has been evading them for so long due to discomfort. I have many patients who after a few days are more alert, more interactive because of the opioids, that they're now getting good sleep. And so they're having a better quality of life while they are awake. People often tell me, when I had morphine previously, when I had surgery, I had a strange feeling, I had nausea, I had vomiting, I must be allergic. So we need to explain to them what the difference is between an allergy and a side effect or an intolerance. And if I see one of those allergies on a patient, even if they're nowhere close to needing opioids in their disease course, we try to talk about it early in the course because we want them to be comfortable. So when there is a crisis and they're really suffering, we do have medication to give them. The other myth is that people should wait. They should hold off on using opioids, using morphine until their pain is so bad, because we want it to be effective later in the disease course when it's really needed. As we know with many things in medicine, escalating pain, just like escalating blood pressure, escalating shortness of breath, any escalating symptom is much harder to manage. Lower levels of medication can often be used when they're used more consistently and starting earlier. So we need to be careful of our dosing. Start low, go slow. Applies to most medications, but definitely to opioids. We need to educate our patients and families that titration is expected, so they're not disappointed, they don't give up and say, see, it didn't work anyway. I often tell people I'm starting at a low dose to reduce the risk of side effects, to reduce any problems you may have, but I expect that I will need to go up on this dose. Remember the role of short-acting and long-acting opioids, as well as that you need to titrate the short-acting when the overall opioid requirements are higher. Always continue supportive care adjuvant therapies. They may allow you to lower your opioid doses and still be effective. So morphine's role in hospice care. When you have your patient at end of life, it's a wonderful tool. We have it to treat our patients. We improve their comfort, their quality of life. It's valuable in part due to the complex symptom loads our patients have. We're often treating shortness of breath, as well as pain, as well as anxiety, as well as agitation, insomnia, all at once, and it can work for multiple symptoms. It also has that ease of administration. Like we said, the Roxanol, the sublingual administration, is so helpful for these patients. But we as healthcare professionals, we need to respect both the drug and its use, as well as people's perception of it, in order to use it most effectively and to have our patients and families accept it when it's needed. We need to be comfortable and knowledgeable so our patients and families will feel the same. And we need to be understanding that the word invokes an emotional response in many that we need to deal with up front, and not just step back and say, okay, if you don't want it, we won't use it, because our patients' comfort needs to be of primary importance to us. Thank you.